Hi, I'm Tony DeMari again, and with Spencer King, we're here at Amsterdam at the European Society of Cardiology meeting, again bringing you some information on late-breaking clinical trials. Spencer, the RAFT trial being presented, an interesting study on the role of beta blockers in patients with heart failure treated with CRT or ICDs.
Yeah, the Europeans have a target for beta blocker dose. So they sort of divided people into did they get at least 50% of the recommended dose of beta blocker or not? And so that's how this trial was structured. And they found that patients who got suboptimal beta blocker dose did worse, but particularly in patients who did not have resynchronization therapy. If they had resynchronization therapy, it sort of blunted that effect. But the overall message in this sub-study was that using suboptimal dose of beta blocker might be adverse for the patients.
Yeah, a common problem actually in the United States, so many studies have shown that patients often are underdosed with all forms of therapy, beta blockers and ACE inhibitors and lipid lowering drugs. And here's some really good information that just giving a beta blocker isn't necessarily effective. You want to give the maximal dose that a patient will tolerate.
Sure, yeah, and that's the effect of the CRT was interesting and hypothesis generating as well, that somehow was a little bit protective. Yeah.
All right, well, serelaxin is a vasodilator that's attracted some attention as treatment for acute decompensated heart failure. There was the RELAX-AHF failure trial presented today.
So these were patients who had acute heart failure, and they were looking at symptoms and overall survival and this sort of thing, and they looked at subgroups. Turned out that really did not show a dramatic difference or significant difference in use of serelaxin.
Yeah, the relaxin study really was kind of confusing because in the primary study they used two different sets of criteria for dyspnea relief, Likert scale and the VAS scale, and had some differences there. Nevertheless, in this study, looking at subgroups with a potential to find subgroup that really responded extremely well, it just didn't yield any positive information.
Yeah, there'll be more on the CardioSource about this, but that's the bottom line, yeah, right now.
Yeah. So the ASTRONAUT study, again, we're looking at a sub-study of a larger trial that evaluated aliskiren in patients with heart failure.
Yeah, so the overall trial was neutral. This direct renal inhibitor was neutral, but the interesting aspect of this sub-study where they divided diabetic patients and non-diabetic patients, they found that disparate results. In the diabetic patients, there was actually problems that resulted. The patients did worse, but there was a benefit documented in the patients who did not have diabetes. So we got a sub-study, and this is hypothesis generating. But it is interesting what the role of direct renal inhibitor has in diabetic patients that might make things turn out worse. I don't know, but this is going to be interesting to follow.
Again, I'm sure that there'll be more information on CardioSource to dissect out the rationale for this very interesting finding of why non-diabetics seem to have a benefit from aliskiren. Typically a lot of skepticism exists in regard to sub-studies, but this was pre-specified, and so that does give it more credence. I'm sure they'll pursue this line of investigation with aliskiren as they go forward.
Sure. The Origin trial is an interesting one. I think we end up with that. Origin is a study that overall was neutral. It's taking patients who have who don't have overt diabetes but have abnormal glucose tolerance, and taking those patients and dividing them into, in this sub-study, patients who developed hypoglycemia. And of course, the patients who were on the therapy with insulin had much more hypoglycemia than patients who were not. But the interesting finding of this study was that hypoglycemia in itself was associated with adverse outcomes. In fact, increased mortality, particularly in the patients who had hypoglycemia but who were not on the insulin therapy. So the control group had that, and the authors themselves conclude from this that hypoglycemia is not good for you, and in particular is probably related to unidentified confounders. In other words, patients who may be sicker for other reasons that resulted in the hypoglycemia.
Yeah, this was another one of those studies that asked the question whether or not more rigid control of hyperglycemia would be of benefit. And in this case, they looked at patients with impaired fasting glucose or impaired glucose tolerance. And as you said, really didn't find that treating these patients with insulin produced any benefit over standard therapy. The insulin, of course, caused more hypoglycemia, and not surprisingly. Hypoglycemia is not good for you, not surprisingly, but it's interesting. It's even worse if you're not on insulin, probably because of comorbidities. I think another nail in the coffin of whether or not by lowering glucose aggressively we can change cardiovascular outcomes.
Yeah, I don't think most of us would jump on these patients without much elevation in their, who were more or less euglycemic to start with, and start out with insulin. So that's something that we probably weren't doing anyway.
Yeah. Well, there's more to come, and stay with us. Check on CardioSource because there'll be a lot more specific information.